they are doing lots of things. So, oh, thank you, Jacob. I forgot to tell you to record, and thank you for seeing me and for doing that. So on the congressional side, they are back in action. They're focused on really pushing through some negotiations and things around that budget reconciliation negotiation process that we've been talking about as they are considering some significant proposed investments around the immigration enforcement and border security areas of things. And then on the Farm Bill side, as well as other broader appropriations, those discussions are also happening and facing an uphill climb in the Senate. More specifically related to the issues that we care about, the Administration for Children and Families, ACF, within HHS has been also putting out some documents this week. On Monday, ACF released the repeal of portions of the 2024 CCDBG rule, rolling back some requirements tied to subsidy payment practices and other program standards. ACF also released a proposed rule for Head Start that would repeal the 2024 regulations related to compensation and pay parity efforts. So these are part of a broader federal shift toward reducing provider requirements and increasing state flexibility. It does raise some concerns around the field with regard to workforce stability, quality investments. If you are interested in weighing in and having your voice heard, that public comment period is open until June 11th. On the state side, Ohio House Children and Human Services Committee met on Tuesday. They heard House Bill 647 for the seventh time. This is one of the major PFCC program integrity bills sponsored by Representatives Plummer and Young. The committee adopted an amendment removing the appropriation that would have redirected some child care cred program funds to support oversight activities. So that money will stay with the child care cred program rather than being diverted. And then House Bill 635 also this is new legislation proposed by the same representatives, Plummer and Young, and received proponent and interested party testimony this week. That legislation proposes to change child welfare practice, including some expanded reporting requirements and information sharing across agencies, as well as some other provisions that would affect young children and children with disabilities. Groundwork Ohio did provide interested party testimony, and again, that was House Bill 635. Without further ado, I'm going to briefly introduce our speakers and then turn it over to them. Richard Stacklin is the Senior Director of Community Impact at First Year Cleveland, with 2 decades of experience in analytic roles in public health, nonprofit, and corporate business, including his most recent role as the lead maternal and child health data analyst at the Cuyahoga County Board of Health, where he was for 13 years. He is really doing a lot of leadership and support around the Partners for Change project funded by the Ohio Department of Children and Youth. And so excited to have him here with us today. And his co-presenter is Dr. Monique Katuski, an OBGYN hospitalist at the Cleveland Clinic, where she's been since 2016, starting as a staff position there at the Cleveland Clinic and practiced general obstetrics and gynecology until transitioning to a full-time OBGYN hospitalist role there in 2020. She has a wealth of knowledge, expertise, experience in this space, and I am going to now pass it over to our presenters today as they are sharing information. Please feel free to drop your questions in the chat, and we'll aim to leave a few minutes at the end for open dialogue as well. So without further ado, I'll turn it over to you, Dr. Katuski and Richard. Thank you.
Thank you, Caitlin. Thank you for the opportunity to present. The sort of meat of this presentation is going to be all of the amazing data work that Richard has been doing for the Partners for Change initiative in Cuyahoga County. And I just wanted to start with some context, sort of defining what we're talking about and why it's important. So hypertensive disorders of pregnancy is the topic of the day. It is a leading cause of maternal and perinatal morbidity and mortality globally. And it complicates, and I want you to keep this number in mind, especially when Richard starts talking about the local data in Cuyahoga County and across the state, 13 to 15% of pregnancies across the United States. So what are hypertensive disorders of pregnancy? What I how I think of them and how I sort of explain them to patients is it's sort of a spectrum of disease, from sort of less severe disease to the most severe manifestations. So on the left side, you see sort of the less severe types of the disease, and there's gestational hypertension, and that's elevated blood pressures. And I put the definitions down there in the right-hand corner. After 20 weeks gestation. So new onset, mildly elevated blood pressures during pregnancy. Chronic hypertension is when a patient has a diagnosis of hypertension prior to pregnancy, or they start having mild range blood pressures prior to 20 weeks. And then the next sort of stage of disease would be preeclampsia without severe features. So that's when a patient has those mildly elevated blood pressures and typically proteinuria, but not the severe features that we see with preeclampsia with severe features. So when a patient progresses to preeclampsia with severe features, that's when they start having those really severely elevated blood pressures that are sustained, and they can have other systemic manifestations. Preeclampsia is a sort of system-wide multi-system disease. So they may have elevated liver function tests, elevated kidney function tests, they may have low platelets, and neurologic symptoms like headache or vision changes. The most severe manifestations of the disease are HELP syndrome. So HELP syndrome is when you really start to see all of those severe features across the system. So you see hemolysis, the red blood cells start breaking down, elevated liver enzymes and low platelets. And then eclampsia is when the patient has seizures. So seizures not attributable to another cause. And I just kind of want to point out, it doesn't always follow this exact progression, but these are just sort of the different stages and the different words that we use to talk about the different manifestations of hypertensive disorders of pregnancy. Next slide. I did want to point out on that slide too, I was talking mostly about hypertension in pregnancy when talking about hypertensive disorders of pregnancy, but do just want to let people know too that preeclampsia can occur in the postpartum period. So super important that patients are aware of warning signs in the postpartum period. It typically occurs within 2 to 7 days of delivery if it's going to happen, but patients can be at risk for up to 6 weeks. So just wanted to point that little caveat out. So in terms of maternal complications associated with hypertensive disorders of pregnancy, this is why it's so important. And this is really scary, what I'm going to talk about. So there are short-term complications associated with hypertensive disorders of pregnancy, and those include placental abruption. That's when the placenta prematurely separates from the wall of the uterus and causes bleeding inside the uterus. And can cause contractions, preterm labor, etc. It's associated with respiratory distress, respiratory failure, can be associated with coagulopathy when the patient's clotting factors are not working, and which can lead to severe bleeding. Hepatic hemorrhage. When we talk about symptoms of preeclampsia, we talk about the headache, the vision changes, swelling. We also talk about like right upper quadrant pain in the upper abdomen, because it can sometimes be associated with liver swelling and even liver hematoma and rupture. Also can be associated with stroke, myocardial infarction or heart attack, and kidney injury. So that was a lot and very scary, but sort of underlines why it's so important to talk about this and raise awareness. In terms of long-term effects, patients who have hypertensive disorders of pregnancy are at increased risk for long-term heart disease, chronic hypertension, increased risk of ischemic heart disease, heart attack, stroke, and chronic renal disease. So it's really important that these patients receive longitudinal care and follow-up. And then I just put at the bottom there, this is the latest data that I could find from the maternal mortality review committees in the United States. This is data from states across the United States, reported by the CDC in 2022. And I just kind of wanted to point out that cardiovascular disorders, which are associated with hypertensive disorders of pregnancy and hypertensive disorders of pregnancy, are contributors to maternal mortality across different demographic groups. But it is particularly high for patients identifying as non-Hispanic and Black. And we know that there are significant and persistent inequities in maternal mortality for this group. So really important to stratify that data, understand underlying causes for targeted interventions to reduce inequities. Next slide. And then when we're talking about fetal and infant consequences, so when the patient is still pregnant, hypertensive disorders of pregnancy are associated with fetal growth restriction or poor fetal growth. Oligohydramnios, that's low levels of amniotic fluid. Again, placental abruption, which has maternal implications and fetal implications. When placental abruption occurs, there's decreased oxygenation to the fetus. And non-reassuring fetal status. So we're seeing signs of fetal distress on ultrasound or externally when we're monitoring the heart rate. All of these things by themselves can lead to premature delivery, either spontaneous or medically indicated. And then for infants, that's that increased risk of preterm birth. And this is sort of where we got to be focusing on hypertensive disorders of pregnancy. We know that prematurity is the leading underlying cause of infant mortality in Cuyahoga County. So with the Partners for Change initiative, there's really a deep data dive looking into underlying factors associated with prematurity. And that's why we sort of focused on this area. And you'll see why when Richard talks about the data. And then, of course, associated complications of prematurity, including difficulties with respiratory function, short-term and long-term cerebral palsy, developmental delays, et cetera. And I just wanted to point out this graph on the bottom, and Richard's going to talk about this a little bit more with his data presentation, but this was a paper from 2023 that looked at 2.6 million preterm births in the United States from 2015 to 2020, and it did show an increasing association of hypertensive disorders of pregnancy with preterm births. So Richard will talk more about the local data related to that.
Thank you, Dr. Katuski. So I took a look at a 30-year time horizon, looking at Cuyahoga County's data, comparing it to the state and national average. In 1995, 3.3% of pregnant people experienced HDP in Cuyahoga County compared to the state national average, which was at 4.1. So in 1995, we were about 20% lower. In 2005, you see that Cuyahoga County's rate of 6.2 increased by 90% compared to 1995. And we were 17% higher than the state of Ohio and 24% higher than the national rate of 5%. And then when you look at it from a 30-year horizon and 10-year time periods, you see the large spike with Cuyahoga County's data. So in 2015, our rate was 11.2, which was 79% higher than 2005. And it's significantly higher than the state and the national average. But in the last 10 years, we've jumped to 27.3%, which is 144% higher than 2015, and it's 733% higher than in 1995. So another way to think about it is, in 1995, 1 in 30 pregnant people experienced a hypertensive disorder of pregnancy. In 2024, it's 1 in 4. When we compare it to the state and national averages, we're about 45% higher than the state and nearly double the United States rate. And some people think, we see a large disparities in infant mortality and some birth outcomes in the state of Ohio and Cuyahoga County. I wanted to take a look at it by insurance type as well as by ethnicity and race. As you see, Medicaid and those that were Medicaid billed births was at 28.6%, which is very close to the private insurance rate of 27.5%. And then when we look at ethnicity and race, we do see that Black non-Latinx mothers experience a higher rate of HDP. But as you see for white, 2 other races, and Latinx, it's nearly 25% or higher. And so this is an experience that is felt throughout Cuyahoga County, with the lowest rate being Asian non-Latinx at 16.7%. Then I want to take a look at, was Cuyahoga County unique, comparing it to the other 4 counties in the state of Ohio. And so in terms of total number of births in 2024, this is the largest 5 counties. Cuyahoga County representing Cleveland, Franklin representing Columbus, Hamilton at Cincinnati, Lucas is Toledo area, and Montgomery is the Dayton area, just for context. As you see, I provided the rates for those 10-year chunks. And you see in 2024, Cuyahoga County's rate of 27.3 was higher than the other 4 counties. And we were 50% higher than Hamilton and about 80% higher than Franklin County. In terms of the 10-year difference, that's looking at 2024 and comparing it to 2015. Cuyahoga County has the largest increase at 144%, with Lucas close behind at 135%. And then looking at it from 2024 comparing to 1995, Cuyahoga County's 733% is still disproportionately higher than other counties in our state. But all communities have felt a significant or seen a significant increase in these hypertensive disorders of pregnancy in their communities. And then just taking a look at the 2024 preterm birth rate for those same counties, you see Lucas and Cuyahoga are significantly higher than the other counties, and we had the highest HDP rate. And so then I want to take a look at, in 2024, I want to do a relative risk ratio analysis looking at, does hypertensive disorders of pregnancy increase the risk of preterm birth? As the data Dr. Katuski has already kind of mentioned, it is significant. And so Cuyahoga County's risk ratio was 1.89. And what that means is if one has hypertensive disorders of pregnancy, the risk of a preterm birth increased by 89% compared to those that did not have HDP in 2024. And as you see, we actually have a lower risk ratio than all the other counties. Montgomery's at 2.35, meaning that those individuals that had HDP, their risk of having a preterm birth increased by 135%. And just for context, for Cuyahoga County's numbers, if an individual had HDP, the preterm birth rate was at 18.8%, and those that did not have HDP, the preterm birth rate was at 10%.
So now I get to talk about the more hopeful part of the presentation. All of that was extremely concerning and sobering. And I just wanted to end with talking a little bit about what we're doing and what we can do to address this really significant issue leading to adverse maternal and infant outcomes in our area and in our state. So number one is to increase awareness. I think that there's a general understanding. I mean, as a OB hospitalist in Cuyahoga County, I knew anecdotally that hypertensive disorders of pregnancy were common, but did not know how significant the problem actually was. So we're really trying to get the word out, and thank you for letting us present to raise awareness about this issue and to get the community informed and engaged. So a major way that we can improve outcomes is improving access to healthcare prior to, during, and after pregnancy. So hypertensive disorders of pregnancy can be managed, health can be optimized, and it's really important to optimize health conditions that put patients at risk prior to pregnancy. And then I'm going to talk a little bit about what we're doing during pregnancy and then after pregnancy too. Like I said, in that, that 6-week postpartum period, really important to monitor patients with hypertensive disorders of pregnancy, either after or between pregnancies. That's also another really important opportunity to connect with healthcare, remain engaged, and optimize health. So because hypertensive disorders of pregnancy are so very prevalent in Cuyahoga County, essentially being pregnant in Cuyahoga County puts a person at risk for hypertensive disorders of pregnancy. So all 3 major health systems, the Cleveland Clinic, Metro Health, and university hospitals have sort of united together and agreed to provide universal low-dose aspirin for pregnant patients. We try to do this at the initial prenatal visit. The society-based guidelines are for risk-based prescription, but this really wasn't effective, especially at getting the aspirin to the patients who need it most. And we found with doing universal aspirin approach, we're having good uptake, and especially for those patients most at risk. So that's been successful so far. And aspirin is a very effective intervention to prevent preeclampsia. If it's started prior to 16 weeks of pregnancy, taken daily up to delivery, it can reduce the risk of developing preeclampsia by up to 50%. So we really want to get the word out about the importance of low-dose aspirin in pregnancy as well. And then blood pressure monitoring. So we really need to be getting patients into healthcare during pregnancy, monitoring those blood pressures to diagnose, monitor, and facilitate treatment to prevent progression of preeclampsia to those severe manifestations of the disease. And there is some preliminary data that Richard has shared with me showing that we've actually had pretty significant decreases in eclampsia, which is really hopeful to me, showing that we are getting patients in, we are getting them diagnosed, we are getting them treated before it progresses to those severe manifestations of the disease. So these are the things that we're currently working on to address this issue. And yeah, so more to come about that in the work for the Partners for Change initiatives in Cuyahoga around this. I'm happy to take any questions.
Thank you both so much. I agree. I think sobering is exactly the word. And I even see someone in the chat who's speaking from personal experience and had an opportunity to work with a high risk OB and experience that low dose aspirin. There is a question in the chat that I'll pose to you. The question is, knowing the race disparities, what efforts has or have Cuyahoga County taken to understand healthcare workforce bias?
Richard, do you want to take that? Or we could talk about it. That's really an integral part of the Partners for Change work. A big part of the Partners for Change work has been partnering with those with lived experience within our community, local community-based organizations, and starting our own very own chapter of Queens Village, which is an amazing program in Cradle, Cincinnati. And really, when we're looking at interventions to address this issue, taking a co-design approach, making sure that the people who are affected are part of the interventions to address the issue.
Angela, I don't want to put you on the spot, but I saw you pop on camera and pop off mute. Is there anything else you want to elevate there?
That, Dr. Monique was very clear about what we are doing. I will say in the past, First Year Cleveland did initially provide racial bias training for all the health systems. And I think as we're continuing to have dialogue with community and folks with lived experience, there is the intention to move forward around how are the systems better collecting information around patient experience and looking at the data to implement, either do more of what's working, because what we've heard is there are providers that are amazing and there's some that may need a little hand holding. And so we're hoping over the next year or so that we'll have a process in place that uplifts, high quality care and provides a clear pathway to getting to high quality care if you need to.
Mm-hmm. Thanks for that. And thanks for that question, Amy. Feel free to drop questions in the chat or pop off mute. I know folks might be thinking or typing, and I'm curious. We like to ask our guests if there's anything on the policy side of things or any legislation that's currently out there that you all are tracking or would elevate to this group of folks that are hungry to engage in that way.
House Bill 396, paid parental leave. We're the only industrialized country that does not have it. Unacceptable.
And Richard, do you mind explaining the connection between that bill and the work that you're doing?
So that bill, the work being done is through Collaborate Cleveland that helped started it, but women are stressed in our communities and not having the opportunities to be able to take, as well as men, to take time off to take care of themselves and their babies. We know one of the major risk factors for maternal mortality is postpartum. And if we're forcing women to make the decision of being able to help provide for their families or take care of their babies and themselves, that shouldn't have to be a choice. Their health and well-being should be number one. And so the fact that, people, especially those that are hourly workers and those that just don't have the time off due to circumstances of the birth or situations that they're in their work, um, it puts them at risk as well as their baby. And so this time off would allow opportunities for families to take care of the family. We talk about, health and well-being for the babies and moms. We should have legislation to support that.
Thank you, Richard. I just dropped that bill in the chat. I saw the Time to Care Ohio Coalition page dropped. Thank you, Stacy, for sharing that. Call your senators, let them know that you're supportive of that legislation. Thank you, Richard. And yeah, Marie, I see you have your hand up.
Thanks. I sit in Akron, Ohio, and I work with the full-term first birthday coalition here. But I also co-chair a statewide collaborative called Ohio Communities for Healthcare and Groundworks and OCHC have recently found each other in a more committed way, which is exciting. But I wanted to talk about policy, which is my thing. We have a Queens Village program here in Akron out of Project Ujima, which is one of our small community-based nonprofits, which is a really exciting entity. But one of the things, if we're gonna I don't know, I'm sorry if it's Richard or Dr. Stacklin, but to your point about we can't, we can't expect people to do things if we don't support them doing it. And one of the things that we are seeing happening with our Queens Village work is that we're like, okay, but who's pregnant here? And who can we charge through to ODM? And who can we not charge through to ODM because they're not pregnant, but we're going to have this thing and we don't want everybody to be there. If we're going to talk about birth spacing, then we're going to talk about people who are not pregnant at this moment, right? That's the goal, is to be not pregnant. And if we're going to talk about delaying pregnancy until you're able to be emotionally present and supported, then we're going to talk about times when people are not pregnant and getting healthy before pregnancy. And to say to our programs that serve this population, sorry, we want those women to do all those things that we're talking about, but we're not going to support the community like Queens Village that really provides that support for women as they're marching through life with all of the other pressures that are, raising their cortisol levels on a daily basis. So from a policy perspective, I think that encouraging resources to not be restricted in a way that silos pregnant people, because then we also see a lot of pressure to have people come into the Pathways hubs and the community health work and first trimester, but we don't have any relationship with them because we haven't had any relationship with them coming up to that, and that's how that happens. So that's a huge policy space that we could, it's hard to know what our opportunities will be come January, but we've made a commitment as a state to infant mortality and maternal mortality, and it really needs to be a real commitment.
Thank you so much for that rich perspective. Yeah, Richard, you have something to add?
No, I just think it's a great point, Marie. And I just think, legislatively, we need to consider who we vote for that would help us and help moms and families in our community. And so I think, using your voice and be able to vote and let that speak for itself.
I think that is a fantastic note for us to end on. I really appreciate you sharing your expertise, Dr. Katuski. Richard, thank you so much, everyone, for joining us this morning and for receiving this information. We will share the recording out and make sure that you have ongoing connection to the Collaborate Cleveland team and the amazing work that they are doing. Yes, join the First Year Cleveland team on September 29th at the State House for their annual Lighting the Way Advocacy Day. Thank you so much, team, for all of your great work and for your partnership. I will let you all go and enjoy the rest of your Thursday. And thanks again for your time. Take care, everyone. We'll see you next week.
Thank you.
Thank you.